All right, good afternoon, everyone. Let's go ahead and start. Today is Saturday, the 27th of February, and we meet after a break. Of course, we didn't have any classes the past couple of weeks, owing to the what our department dean lovingly referred to as a snowmageddon or snowvid. Okay, so yeah, those are some types of terms that were used to uh, basically try to describe what happened. So we got hit by an Arctic front, and even though I did talk about the impending weather the last time that we talked, I don't think anyone foresaw the magnitude of the problem. We were clearly underprepared for that here in Texas. So most of us sat through anywhere from 24 to 72 hours of no power, no water, no gas in some cases. So I myself was out of power for almost 2.5 days. So almost 72 hours. And fortunately, we did have some running water, not hot water, of course. In the absence of power, that was not possible. But we did pull through, and I'm hoping for the same for all of you. Hopefully, you're all staying safe and uh, you were able to manage things during this trying time. So, just a reminder from nature that we are very much a part of all the global ecosystems, and nobody's really above nature, above the laws of nature. And the problem is, I keep coming across many different discussions where people are talking about how things are getting worse. You have the pandemic, and then, of course, the weather pattern, the Arctic front that rolled in. And so, what I have to say there is, again, uh, nothing new. Okay, so pandemics, natural disasters, climate patterns, they have been with us ever since life began on the planet, even before there was life on the planet. The only thing was we didn't have social media back then. And social media could be a great thing. It could also be uh, not such a good thing and when it is being used to promote things like paranoia and false statements, distorting science, sacrificing science at the altar of politics and philosophies and those kinds of things. So these things have always happened, all right? And what these forces of nature do is they just weed out different life forms. This is something called natural selection. Natural selection is what causes all species to prosper, to thrive. And as cruel and cold as it might sound to our human sensibilities, that's the law of nature, right? So it weeds out certain life forms, and only those that are deemed fit, biologically fit, survive and go on. So it's the same thing happening here. Somehow we got this idea that we are above nature, we are above the rest of the life forms, and we are insulated from these forces. Maybe with modern technology and vaccinations and better hygiene, we have overcome uh, some of those factors to some extent, but we are still very much a product of evolution, a product of natural selection. And so these are basically reminders, okay, that we need to stay close to our true nature and stay in shape, basically, right? And the best vaccination, the best defense against any virus or any bacterium is a good, healthy immune system. How do you get a healthy immune system? You eat right, right? You stay away from greasy, fatty, inflammation-inducing foods, fast foods, fried foods, basically, which is unfortunately the staple of the American diet. You eat more whole grain, wholesome foods, organic foods, right? Stay away from sugary stuff, whether it's energy drinks or sodas or Coke or whatever your beverage of choice is. Of course, you can indulge in those periodically. At sometimes, but if it's a staple that you're consuming on a regular basis, you're not going to have a healthy immune system, right? And also social distancing is all well and good, but you also have to realize that all species flourish and thrive and reproduce by coming together, not by staying apart. So there has to be a balance, right? So you have to have common sense measures. Someone is sick, sneezing, sniffling, coughing. Of course, you maintain your distance. You quarantine the person, but at the same time, there's no reason why you should be in a complete bubble by yourselves with no contact whatsoever with any other life form. Because if you do that, your immune system won't develop. The immune system develops when you're exposed to these factors, all right? And when you do get sick at times and you recover with healthy hygiene and good eating habits and all that, and that's how you develop active immunity. But if you are staying away from life as is, uh, the next time that you have to walk out, which you will have to eventually, you won't have a functional immune system. So some of these things that we have to keep in perspective and not get carried away with what's going on around us. So just quickly make a note here. Um, let's see, and immune systems and natural selection. Okay. All right, so moving on, I did send out your study guide for lab exam number 1, which will be coming up this Saturday, next Saturday, the 6th of March. So please feel free to take a look there and use the study guide to the best of your abilities. And that lab practical will be posted on the Connect website again. It's 8 to 9:30 p.m., 90-minute exam. I have basically uh, clarified what that exam entails, what you can expect to come across. I also sent out your lab exercises, which will be due for next Saturday as well. And as you can see, I've combined the 2 labs from what we missed last week and also this week. So you will have to work a little uh, overtime in order to make up for those exercises. Don't get overwhelmed though. Just work to the best of your ability and share your work with me, okay? As I had mentioned earlier, do not be too concerned about being technically correct every single time. As long as I see your effort there, that should be good. Okay, so with all those reminders, let's go ahead and take a look here. So we are on slide number 79 on chapter 19, the heart. And hopefully you remember some of our discussions about what the heart is and how it functions, what are the different parts of the organ. And right now we are talking about the electrical workings of the heart. So remember, your heart is a natural pacemaker, okay? It generates its own electrical rhythm that keeps it going. So that's what we are focusing on here. So where does this heartbeat start? It starts in your right atrium. And the place where it starts exactly is called the SA node, for sinoatrial node, okay? So what happens here is it spontaneously depolarizes, which means it releases electrical pulses, okay? Depolarization means the inside of the cell gets more positive, okay? So something to remember, depolarization equals more positive on the inside, okay? Repolarization means more negative on the inside. So some things to keep in mind. All right. So here we are looking at something called the RMP, which stands for resting membrane potential. What does that mean? When your heart is not contracting, doing anything, what is the general, usual, normal charge inside? It's about negative 60 millivolts, okay? So it's still a little on the negative side, as you can see. Uh, what keeps it negative? What keeps it at negative 60 millivolts? Something called the sodium potassium pump, as you can see here. What does the sodium potassium pump do? These pumps, which are like dispersed, scattered throughout your heart muscle, they pump out 3 sodium ions and in exchange bring in 2 potassiums. Now, if you look here, both sodium and potassium are positively charged. You can see the plus signs there. They are cations, okay? So imagine if you're pumping out 3 pluses and replacing them with only 2 positives, what is going to be the net charge there? Is it going to be positive or negative? It's going to be negative. So the sodium potassium pump is responsible for maintaining this negative 60 millivolt charge inside of your heart cells, okay? You also have other types of channels like the calcium ion pumps, the leak channels, and those kinds of things, as well as these slow voltage gated sodium channels, then the fast voltage gated calcium channels, and the voltage gated potassium channels as well. So the fact that your heart is beating in the synchronized fashion every minute, every second of your life has to do with the workings of these channels. So we shall see how that works, okay? So first up, you can see that your resting membrane potential in your heart cell, in fact, in your SA node, nodal cell. This is your sinoatrial node, that dime-sized area in your right atrium that generates the electrical impulse. It's a negative 60 millivolt value, as you can see here. And what maintains that? These guys here, where are they? The sodium-potassium pumps, okay, which are not shown here in this picture, but they are the ones doing this job here for you, okay? At the same time, you have these voltage-gated pumps, the slow sodium channels, and then the fast calcium channels here as well, as well as the potassium channels, okay? So what happens here is when the sodium channels open up, the sodium starts to flow in. And when the sodium flows in, sodium is positively charged, the inside is going to become more positive. This is what depolarization is. The inside's becoming more positive because the sodium channels are open and the sodium ions are moving in. Okay, that's depolarization. And then the calcium channels follow soon. They open up as well, and calcium flows in too. Now remember, calcium is also positively charged. That's also cation. So the insides become even more positive. Eventually, these two will close, and then the potassium channels will open up these. When the potassium channels open up, then the potassium ions start to flow out. This is called repolarization. Again, potassium yet again is a cation. It's positively charged. So when the potassium channels open up, the potassium starts to flow out. The inside becomes more negative or less positive, and this is called repolarization. Okay. So there you have these terms, depolarization and repolarization. Okay. So how do your SA node or your sinoatrial node cells maintain their autorhythmicity, which means they spontaneously uh, depolarize and repolarize, right? They're firing electrical signals because they have these slow voltage gated sodium channels which open up randomly, spontaneously rather, as you can see here, the sodium flows in and the inside becomes more positive. How positive is that? From negative 60 to negative 40 millivolts, as you can see. And this negative 40 millivolts is the threshold value. What that means is once you get down to this level, negative 40 millivolts, that much positive, that's when the electrical impulse starts to fire, okay? So then depolarization is when the fast voltage gated calcium channels open up as well. The calcium cations flow in, the insides become even more positive. How positive is that? Well, from negative 40 millivolts to just about 0 millivolt here. So even more positive. That's your depolarization. So the heart is now, or the SA node of the heart is sending out these electrical impulses. And then finally, repolarization starts. That's when the calcium channels close and the voltage gated potassium channels open up. So then the potassium ions start to flow out, the insides start becoming more negative, and then they go back to their negative 60 millivolts, which is their resting membrane potential value as is, okay? All right, so yes. So, and then again, the sodium channels open all over again at negative 60 millivolts, and the whole process starts over and over again. So that's what keeps your heart beating, right? It starts beating when you were a 4-week-old embryo, uh, all right, inside of your mother's womb, and it'll keep beating till the day you pass away. So that's what it is. All right, so the SA node, as you can see, the action potential starts about 0.8 seconds after the last. So there's a time interval, a time lag of about 0.8 seconds. So when you do the math, that means your basic heart rate is 75 beats per minute. That's the average, okay? However, different people have different heart rates. Some people when they're at rest might have a heart rate of much less than that, 60 beats per minute. 50 beats per minute. If you are a conditioned athlete like Lance Armstrong, right, the famous cyclist, he has a resting heart rate reportedly of about 33 beats per minute, as does Michael Phelps, the Olympic winner swimmer, okay? So because they're conditioned athletes, their heart rate is much lower, and we shall see how that works. On the other hand, if you're an anxious person or if you have a fever, or if you're hyperthyroid, then you might have a resting heart rate of 100 beats per minute. So there's some variation. The average mean, though, is about 75 beats per minute, as you can see here, okay? And in fact, your heart does, your SA node does fire at a higher rate, 100 beats per minute, but the vagal tone, which means the discharge from your vagus nerve, which is your cranial nerve number 10, and that's a parasympathetic nerve. Parasympathetic means rest and digest, right? Slow down nerve. It keeps it at a lower rate, about 75 beats per minute, as you can see. So here in this graph, you can see all of these electrical happenings going on, right? So the resting membrane potential is negative 60 millivolts. That's when the slow sodium channels open up, sodium starts to move in, you become more positive till you get to this point, negative 40. This is the threshold. Now the fast calcium channels open up, all the calcium goes in, so there's a rapid uh, surge of positive energy inside of the cell, which is called depolarization. It goes all the way up to 0 millivolts. That's when the calcium ion channels close and the potassium ion channels open up. The potassium starts to flow out. You start getting more negative, and this is repolarization happening all over again. And you go all the way down back to your negative 60 resting membrane potential. And then the cycle starts again and again. So that's what you're seeing here in terms of your uh, slow sodium, fast calcium, and your potassium channels. All right, so what are these pictures showing us here? What they're showing us is the time lag that is involved in between your SA node right here. See, that's your right atrium, firing its electrical signals, and those electrical signals moving throughout your cardiac muscle here, right? And so there's some time lag in what you're seeing here. This is your AV node, atrioventricular node, because it's in between your atrium, right atrium, and your right ventricle, right? So this one picks up the electrical charge from here, and then that fires the electrical activity further down through the bundle of His, as we mentioned before, then the right and left bundles, and then the Purkinje fibers, right? But there's a time lag at each uh, point, as you can see here. Why do you need a time lag? Why should there be a delay in between the spontaneous depolarization at the SA node and then the spontaneous depolarization at the AV node? Why do you think this time lag is needed? Because you don't want your atria, these two, to contract at the same time as your ventricles, right? That'll be a disaster. If your heart is just contracting at the same time, it's going to burst. The blood is not going to go anywhere, right? It's going to just be playing ping pong within. That should not be the case. You should have your atria contracting a fraction of a second before the ventricle, because when that happens, the blood is actually has time to be pushed down into your ventricle, and then the ventricles pump them out into your pulmonary trunk or your aorta, depending on which ventricle you're talking about. So that's why this time lag is important, okay? You need that fraction of a second delay so that your atria contract marginally before your ventricles do. And so that's what we're looking at here. And this is the path of the electrical current, as you can see, right? From the SA node to the AV node, down the bundle of hairs, the right and left bundles, and then the Purkinje fibers. So right there. Okay, so what else do we have here? All right, something called an ectopic pacemaker. What does that term even mean? Ectopic means someplace else, someplace outside of the normal situation. So your normal pacemaker is your SA node. But should your SA node fail, all right, so what is the most common cause of your SA node failure? Heart attacks, right? So kind of like a clot, blood clot, or a cholesterol embolus, a ball of fat that has clogged up your one of your coronary arteries. Okay, and remember which coronary artery is called the widowmaker, the left anterior descending, the LAD, right, or the anterior interventricular artery. That's the important one, right? So that might cause a failure of your SA node. It stops working. So what happens when your SA node is non-functional? Do you die right away? No, fortunately not. If SA node is impaired, then your AV node takes up the slack and it starts pumping, generating those electrical impulses. Nonetheless, this is much slower than the SA node. So you only can generate from 40 to 50 beats per minute, okay? But it's fast enough to sustain life, you won't die. But what happens if the heart attack, the area of the heart impacted is bigger? So both your AV and your SA node are dysfunctional, taken out of action. Then any of your heart muscle, any other cardiac muscle will start spontaneously contracting itself, right? However, the maximum that you can go with your cardiac muscle is anywhere from 20 to 40 beats per minute. This is too slow to sustain life, okay? You might be alive when you're lying on a stretcher or on a gurney or in your bed, but the moment you start getting up and walking around, the heart's gonna fail at that point. So what is the resting membrane potential of nodal cells? Negative 60 millivolts. What is autorhythmicity? The heart's ability to generate its own electrical impulse. It's a pacemaker on its own. Describe how nodal cells function as autorhythmic cells to serve as a pacemaker of the heart. They depolarize spontaneously. The SA node depolarizes, right? What is the path of an action potential through the conduction system of the heart from the SA node down to the AV node, then down to the bundle of His, then the right and left bundle branches, and then to the Purkinje fibers. And then this starts all over again. What anatomic features slow the conduction rate of the action potential as it passes through the AV node? Uh, well, there's a little area of muscle involved that the electrical impulse needs to travel from the SA node to the AV node. So that slows it down. What is the function of this delay? So that the atria can contract earlier than the ventricles, that both of them don't contract at the same time. All right. So now from the nodal cells, from the SA node cells, let's talk about your other heart cells, not your nodal cells in the right atrium, but the rest of your cardiac muscle cells. So they have the same apparatus. They have the sodium potassium pumps, they have the calcium pumps, and the sodium and potassium channels, as you can see here, right? Okay, so what that means is that your cardiac muscle cells, not your nodal cells, but your other cardiac muscle cells, have a resting membrane potential of negative 90 millivolts. So they are more negative than your SA node resting membrane potential, which was only negative 40. These ones are negative 90, okay? So what does that mean? It means it's a little harder to excite your cardiac muscles. Your SA node cells get excited easily because they are at a lower, less negative value, negative 40, but it's a little harder to electrically excite your cardiac muscle cells because they have a resting membrane potential of negative 90 millivolts, as you can see here, okay? Nonetheless, they get excited in the very same way as your SA node cells. All right, so how that happens? Again, fast voltage gated sodium channels open, sodium starts flowing into the cells. This is called depolarization, and they become positive from negative 90 all the way to positive 30 millivolts. Okay, so at that point, you reach something called a plateau, and the plateau means that your voltage gated potassium channels and your slow voltage gated calcium channels open up as well at this point. So the potassium starts to leave the cell, exit the cardiac muscle cells, which is repolarization. All right. But at the same time, the positively charged calcium ions are entering. So they're kind of canceling each other out, right? The positive potassiums are moving out, but at the same time, the positive calciums are moving in too. So it's kind of like a plateau. No change in the electrical charge at that point. Okay. So the membrane remains depolarized. And then repolarization. That's when the calcium channels close while the potassium channels remain open. The positively charged potassium ions are moving out, and you get more and more negative on the inside, which is called repolarization, till you go back all the way down to negative 90 millivolts. Okay, so here you can see this is your resting membrane potential in your heart muscle cell. Uh, at this point, the sodium channels open up, sodium starts to flow in, you become positive, 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 all the way up to positive 30 millivolts. That's when the calcium channels open up as well, and the potassium channels open too. So the potassium starts to move out, which is positivity going out, but there's also calcium moving in at the same time, so positivity moving in too. And so that's the plateau here. At this point, now the calcium ion channels close and only the potassium ion channels are open. So potassium keeps moving out, and then you start getting more and more negative, which is called repolarization, till you retain or regain your negative 90 resting membrane potential. Okay, so there. So the question is, why do you need these calcium ions to move in? You need these calcium ions to move into your heart cells to make it contract. Your heart contracts with the calcium ions. Okay. Uh, and how does the calcium help the heart contract? Well, in a number of ways. So first step, it helps your uh, cardiac muscle contract by binding to a protein called troponin. So troponin is basically, uh, it's kind of like a, a covering to your um, myosin and actin fibers. No, actin and myosin fibers were two types of muscle fibers, protein fibers that make your muscles contract. Now they are being held in check by means of troponin. So to move the troponin out of the way so that the muscles can start contracting, you need calcium to do that. All right, so remember it that way. Okay, so also remember that the cardiac cells have a long refractory period. What that means is they do not recontract. Your heart does not recontract right away. They have a much longer refractory period as compared to the skeletal muscles, okay? So the refractory period in your cardiac muscles is about as long as 250 milliseconds, okay? And so what that ensures is that your heart is not contracting all at the same time. It makes sustained or tetanic contraction impossible, okay? And so, by the way, this is why you die when you get electrocuted. If you get a huge surge of electricity running through your system, such as when you're struck by a lightning strike or something, right? Or you touch a live wire with a lot of electrical voltage there. What that electrical surge does, it stops your heart. It makes it go into tetany, exactly this, right? Which is something also called ventricular fibrillation, ventricular VFib. You'll see it if you work in the cardiac unit in the hospital. So your heart just contracts all at the same time, the blood flow stops out of it, you die, okay? And interestingly, when they administer those shocks that you see in all those movies, right? These paramedics jumping in and shocking the patient, something called AED for automated external defibrillator. What they're trying to do there is the very same thing. They're shocking your heart into stopping, not starting it, to stop the heart. Why? Because then once it stops, then it has you're rebooting the heart. So hopefully it'll come back to its normal sinus rhythm, okay? It'll start contracting with the right rhythm. So that's when you shock a patient, when the heart has stopped beating altogether, or the heart is in arrhythmia, like it's contracting out of sync. So you try to resync it, to reboot it by stopping it, by giving it that shock from the AED device. So let's talk about AED, and let's see, and lightning strike, and arrhythmias such as VFib, ventricular fibrillation, uh, and normal sinus rhythm, NSR. So please feel free to look up these terms, these notes that I'm going to share with you as usual. Feel free to look those up on Wikipedia, YouTube, all of those, all right? You'll find very useful, helpful information clarifying all of these terms that I'm going to use here. Okay, so there you go. Look at the skeletal muscle. It depolarized, the resting membrane potential is again negative, well, more than negative 90, I'd say about negative 100. And then it gets depolarized here, the sodium ion channels open up, and it goes all the way up to positive 30, and then repolarization starts happening, which means the potassium channels open up now, right? Uh, so there's barely any plateau. There's just rapid depolarization and repolarization. Now look at the heart's, well, this is again skeletal muscle. If you repeatedly give it jolts of electricity, then it starts contracting at higher and higher rates till it reaches a point where it's completely contracted in tetany. That's what tetany is, tetanus, right? Your muscles are completely contracted, and then it fatigues, it fails, right? It's like when you lift heavy weights, you can only lift them up to a certain point, and then it gives in. You have hit fatigue. Now, how about the cardiac muscle? Look at that. Cardiac muscle, slow depolarization from negative 90 all the way up to what? Up to 0 millivolts, and then slow repolarization, as you can see, all right? So it's much slower. The refractory period is much higher in your cardiac muscle. Okay, so next up, what we're looking at here is an EKG or ECG, which stands for an electrocardiogram, this reading, the lines, the squiggly lines that you will see on a strip of paper or on a cardiac monitor, whichever instrument or tool you're using. So let's talk about what forms these squiggly lines and what they represent in an EKG. So first up, here's the baseline, okay? Your heart at rest. This is your heart at rest. And then you see this small blip called the P wave. What the P wave is denoting, what causes the P wave is your atria contracting, the upper chambers of the heart, the atria contracting, okay? So this is also called atrial systole, systole, S-Y-S-T-O-L-E, your atria contracting, okay? Smaller blip. Then there's a gap, uh, Remember, there's a time delay between your atria and ventricles contracting. Here's the time delay. And then a much larger peak, QRS. What is that? This is your ventricle contracting. Since the ventricle is much larger and much more muscular than your atria, look at the difference in their blips as well. Atrial contraction or atrial systole or atrial depolarization. This is ventricular systole or ventricular contraction or ventricular depolarization, the QRS complex. This is your ventricles. Then again, there's a gap, time delay involved here, okay, till you get yet another blip called the T wave here. The T wave is your ventricles repolarizing. This is ventricular repolarization or ventricular diastole. It relaxes here. How does it relax? The potassium ion channels are opened up. The potassium is flowing out. What caused these blips here? Depolarization. The sodium ion channels were open up. Sodium was flowing in and calcium was flowing in too. So this is repolarization, T wave, okay? Then there's a gap, and then the cycle starts all over again. So this is an EKG from a person who is in normal sinus rhythm, healthy person, hopefully me and you as we speak here. But there can be many things that can go wrong with your EKG. For example, what if, let's say, this gap, which is called the PQ segment, this time interval between your P wave and your QRS complex is prolonged? What if this line is longer than it is here? What does that tell you? There's a gap, there's a time delay, there's a heart block in the time in between when the atria contract, the SA node here, and then that contraction is carried down to your ventricles. There's a time delay. What is causing that time delay? Could be a number of things. For one, dead muscle tissue, it's scar tissue, will cause the electrical impulse to travel a longer distance, to detour from the dead muscle to get to the ventricles. What is the main cause of dead muscle in your heart? A good old heart attack, right? Or bad old heart attack, I should say. Myocardial infarction. Part of your heart cell is dead, and therefore part of your heart muscle, your myocardium is dead, and therefore the electrical current has to travel a farther distance. That's a heart block. You have 3 degrees of heart block: first degree, second degree, and third degree. First degree is minimal. Third degree is when it's not even compatible with life. There's a disconnect between your atria contracting and that electrical current is not carrying down to your ventricles here, okay? So this will tell you that. What else can you see? What if your ST segment is elevated, something called ST segment elevation? So this line is up here. Instead of here, this line is elevated. So ST elevation. Usually it signals a heart attack. It signals myocardial ischemia or a lack of blood supply to your heart muscle, okay? So it's called a ST elevation or STEM or a STEMI for ST elevation myocardial infarction, okay? STEMI. Uh, ST elevation myocardial infarction, a heart attack that is shown or represented as the ST segment being elevated higher up here, okay? Or something else you might see here is what is called a T wave inversion. T wave inversion, which means you see how the T wave is like this way? Sometimes it will be the opposite way. It will be going downwards like this, T wave inversion. That also shows you myocardial ischemia or a heart attack, lack of blood supply to your heart muscle, okay? So both of them, those indicate, excuse me, myocardial ischemia. All right. So here we are looking at what those intervals are all about, what they actually indicate, right? Heart rate, heart rhythm. We talked about some of the potential things that can go wrong on an EKG and how to look for those, all right? For example, uh, again, P wave, and then the QRS complex, and then here's the T wave here, all right? So heart blocks, these were the 3 different degrees that we were mentioning before: first degree, second, and then third degree. First degree heart block, PR is a little prolonged, slow conduction, but it's still there between atria and ventricles. Second degree, some action potentials do not reach the ventricles from the atria, period. Third degree AV block, complete. So none of the electrical impulses are going down from the atria down to the ventricles. This is not compatible with life, okay? Is the major cause of these blocks? Heart attacks, myocardial infarction. So remember, cardiovascular disease or coronary artery disease is the #1 killer of people, human beings all across the planet. Why? Diet, exercise, stress, our modern way of life. We have dissociated ourselves from our healthy, natural lifestyle that used to be the case when we were not all urbanized, and so we are ending up with such drastic increases in cardiac illnesses. Okay, much of this can be prevented using uh, all the diet and exercise patterns that I've mentioned before. Okay, all right. So PVCs for premature ventricular contractions. So here you have uh, an added ventricular contraction, something in addition to the normal contraction. Okay, most of the time they are harmless. They can happen because you are maybe a little stressed at times, you drank too much coffee, you did not get a good night's sleep. These kinds of things will induce premature ventricular contractions often. Okay, so harmless. But if they are persistent and they're leading to signs and symptoms like palpitations and sometimes even fainting episodes when you're passing out, then you certainly need uh, to work this up. What exactly is going on? It could be something more serious, right? VFib or ventricular fibrillation, as you can see, chaotic electrical activity in the ventricles, such as when you get struck by a lightning strike, right? So the heart goes all crazy. And so how you treat that is with an AED. Remember, you shock the heart into stopping it. You're trying to reboot the heart. You just like if your computer freezes, what do? You shut everything down and you restart the computer system, hoping for the operations to resume by themselves. Same thing here. Well, which voltage-gated ion channels are open during repolarization of cardiac muscle cells? Potassium ion channels. How does the refractory period of cardiac muscle cells compare to that of skeletal muscle cells? Cardiac muscle cells have a much longer refractory period. What is happening electrically and mechanically during the QT segment of the ECG? Ventricular diastole or ventricular relaxation or ventricular repolarization. All right, so all right, let's talk about a few important terms here. Um, okay, so what you have to remember here is remember what causes the heart sounds, the S1 and the S2. The S1 was what? Your AV valves closing, not opening, right? What was the S2 sound? Your semilunar valves closing. Uh, what were your AV valves? The right AV valve and the left AV valve, right? What were your semilunar valves? The aortic semilunar valve and the pulmonic semilunar valves. So remember those things. Something else we're seeing here is something called stroke volume. This is important, okay? What is stroke volume? Stroke volume is the amount of blood ejected by your ventricles with each heartbeat. It's about 70 milliliters of blood in a normal average individual. But if you're a conditioned athlete, it could be anywhere from 110 to 150 milliliters, right? Much, much greater than a non-athlete. Okay, so that's the stroke volume. Okay, ventricular balance, what does that mean? Equal amounts of blood are being pumped by left and right sides of the heart. So remember what happens when your right side of the heart fails. You get what? Blood backing up in your system, something called systemic edema. You swell up, your feet especially get puffy, they swell up, and you check for edema. And I mentioned that previously, right? What happens if your left side of the heart fails? Then the blood backs up into your lungs and you develop pulmonary edema, fluid in your lungs. So you get those bubbling sounds when you breathe, difficulty breathing, dyspnea, and all those kinds of things, right? So both sides of your heart should be pumping equally. So you don't end up with right-sided or left-sided heart failure. Okay, so pressure changes that occur during the cardiac cycle are responsible for what two physiologic processes within the heart? Pressure changes, well, the valves opening and the valves closing. What is occurring during ventricular ejection? The blood is being pushed out of the ventricles into the great blood vessels. What pressure changes cause the closing of the AV valves and the opening of the semilunar valves? The ventricular contraction does it. When the ventricles contract, the AV valves close back up. Remember, they don't open up all the way because of the chordae tendineae that are holding them down to the papillary muscle, right? So they only open up this much. They don't go all the way up. You don't want the blood to go back up. So this. And then the semilunar valves open at the base of the great vessels. This is ventricular contraction. Um, Define end diastolic volume, the amount of blood that stays back in your ventricles at the end of full relaxation of your ventricles. And systolic volume, the maximal volume of blood remaining in your ventricles at the end of maximal contraction or systole. Stroke volume, the amount of blood pumped out by your ventricles with each heartbeat. Okay, how are they related? If you have a healthy stroke volume, then those values are all normal. If you have a failing heart, then both your end diastolic volume and your end systolic volume would be greater because you're not pumping out all the blood as you should. So what is cardiac output? That's a useful formula. The cardiac output will tell you how healthy your cardiovascular system is, if you're doing a good job with your diet and exercise and your heart status, your cardiac status or not. So how do you basically calculate your cardiac output? Let's take a look here. So the formula is your heart rate times your stroke volume, okay? So what was your stroke volume for an average non-athlete person? 75 beats per minute. What is the average heart rate for a average healthy human being? It's about uh, 75 beats per minute, right? The stroke volume was about 70 milliliters with each heartbeat. So you multiply 75 beats per minute with 70 milliliters per beat, and you get 5.25 liters per minute. This is the average normal healthy cardiac output of an average person. Now, again, this does not apply to the outliers, the extremely athletic or the extremely diseased or lazy or whatever you want to call it, okay? So as you see here, uh, individuals with smaller hearts have smaller stroke volume and so must have faster heart rate. Now, that makes sense why women and children have faster heart rates, faster pulses as compared to men. Because in general, since women on an average have a lower body mass index than men, and children as well, of course, uh, so their hearts are smaller, so their stroke volume is a little smaller. So how do they maintain normal cardiac output? Stroke volume is small, increase the heart rate. So that's why their heart rates, their beats per minute are usually higher than men. And how about individuals with, excuse me, with large hearts, like Michael Phelps and Lance Armstrong, right? I mentioned those individuals in regards to heart health. And now they are conditioned athletes, of course, right? So if you look at those people, how can they get by with something like only 33 beats per minute? If you showed 33 beats per minute when you presented at the ER or at the doctor's office, you would be declared dead or in a coma. And these people, of course, are not. In fact, they're functioning at the very high end of physical performance. That's because of uh, good genetics and exercise and also conditioning. They have larger, more muscular hearts. Therefore, their stroke volume is much higher than an average person. They can get by just well with a lower heart rate. Okay, so now that makes sense. Cardiac reserve. The more healthy and physically active you are, and the good your diet, and you lower your stress levels, the greater your cardiac reserve. Uh, Lance Armstrong and Michael Phelps have great cardiac reserves, which means if they need to rush up, their pulse will barely budge from 33 beats per minute to, let's say, 38 beats per minute or 40 beats per minute, and they will get all the work done needed with that amount of minor increase in their pulse rate. On the other hand, if you have to do some work, extra work, and your heart starts pounding and your pulse goes from a 90 at rest to 120 or something, not a good situation to be in. Now, you can certainly do with some more healthy diet and exercise and all that. So your cardiac reserve is not all that good, okay? So that's a good measure of uh, how your heart is doing at any given time. Okay, so next up we are looking at what are called chronotropic agents. So chronos means time, right? So chronotropic agents either speed up your heart or they slow down your heart. If they speed up your heart, they're called positive chronotropic agents. If they slow down your heart, they are called negative chronotropic agents. So what are some examples of positive chronotropic agents, ones that speed up your heart? The best known ones, of course, are adrenaline, your fight or flight hormone, also called norepinephrine or epinephrine, right? So what they do is they increase your heart activity. They increase the firing rate, as you can see here, right? There it is. There's norepinephrine, adrenaline being secreted from the neurons. And what norepinephrine does is it opens up your sodium and calcium channels even more. So more and more positivity flows into your cardiac muscle cells. And so they make your heart rate go higher, okay? Thyroid hormone will do the same. So if you're hyperthyroid, remember one of the things you see in hyperthyroid people is tachycardia. Beat, their hearts beat much faster than an individual than in a normal individual. And so how thyroid hormone does that is it increases the number of beta 1 receptors, the receptors that respond to adrenaline. Caffeine will do the same. If you drink coffee or caffeinated drinks and you're not conditioned to those, they will also cause your heart rate to go up, okay? So there are some examples. Cocaine, certainly, right? That's another good way of increasing your heart rate. And any of these substances in excess are dangerous. Nicotine from cigarette smoke, tobacco, because all of them cause your heart to speed up. And if you already have some heart condition, pre-existing heart disease, and you're using these substances, even for a healthy individual, your blood pressure rises, you're always at an increased risk for getting a heart attack or a stroke, an artery blowing in your brain or something, okay? So then what are the negative chronotropic agents? They slow down the heart. Parasympathetic activity, uh, like what? Like some beta blocking drugs. They block your beta receptors, which respond to adrenaline, right? And so these beta blocking drugs are used for treating high blood pressure, okay? They treat high blood pressure because they block the beta receptors. And there's many different examples of these beta blockers, right? Uh, like non-selective ones like propranolol. So these the LOL drugs, right? Propranolol, uh, atenolol, right? Labetalol. All of these are examples. The LOL ones, as I mentioned, these are all beta blockers, okay? All right, so atrial reflex, very simple. The greater the amount of blood returning to the heart, the greater the amount of blood being ejected from the heart. It's simple. The more that you stress the heart with blood, the stronger it will beat and more uh, volume of blood will be pumped out as well. So a venous return, how can you increase the amount of blood returning to your heart right now? By exercising. You start getting up and moving around, and so that increases the amount of blood that is returning to your heart, and your heart is having to pump higher amounts of blood out. And it's a great way of strengthening your heart. Exercise, just move about, right? Don't be in one place for long periods of time. So that is what it is. So what is then this term called preload? Preload is the amount of blood returning to the heart. So how do you increase preload? By exercising, okay? So Frank Starling law, same thing. The greater the amount of blood returning to the heart, the stronger and the more powerful the heartbeat and the heart contraction, as you can see here, okay? All right, so what else? Venous return. If you have blood loss going on for whatever reason, you got shot or you stabbed or something and you're losing a lot of blood, or you have an ectopic pregnancy that blew up, or a gastric ulcer that blew up or something like that, so not much blood is returning to your heart slows down. It gets weaker and weaker because of blood loss. Again, Frank Starling law, okay? So next up, we are looking at what are called inotropic agents. What does that mean? Inotropic agents, uh, if they're positive, they increase the power of your heartbeat. If they're negative inotropic agents, they weaken the heart, okay? So positive and negative inotropic agents. All right. So what are some examples of positive inotropic agents? Drugs like digitalis. This is a drug which strengthens the heart, and it's derived from a poisonous plant, interestingly, of the foxglove family. Foxglove. The plant is called deadly nightshade, okay? Deadly nightshade. If uh, taken in or ingested in large quantities, it will cause your heart to basically go into ventricular fibrillation and you die, right? But the same drug, when properly used, the same substance can be used as a heart booster. It will boost the heart rate in someone who's having heart failure, okay? So thyroid hormone, adrenaline, all of those are positive inotropic agents as well. So what are some negative inotropic agents that that weaken the heart? high levels of potassium or acidity in your blood, like if you are going into diabetic ketoacidosis because of diabetes, that will weaken the heart, okay? Calcium channel blockers or beta blocking drugs, all of them can do that as well. So what is the afterload? The amount of pressure against which your heart has to contract. So if you have high blood pressure, then your heart is having to pump and work extra hard. There's already so much pressure in your arteries, and your heart has to pump against this increased pressure. So that is increased afterload. And as people get older, as you can see here, seen with aging, especially if you're unhealthy diet, lots of fried, greasy foods, high fat foods, and those kinds of things, and lack of exercise, your afterload, your blood pressure will increase with time, okay? So again, stay healthy, okay? Stay active, watch what you eat. Okay, so heart rate and stroke volume. We talked about how when you multiply these two variables, that's how you get your cardiac output. So keep that in mind. Bradycardia is clinically slow heart rate, less than 60 beats per minute, as you can see, which is considered normal if you're a conditioned athlete, but it can also indicate something like hypothyroidism or congestive heart failure or a first degree heart block or some those kinds of things, okay? Tachycardia, when your resting heart rate is greater than 100 beats per minute, either you have fever, you're anxious, you have hyperthyroidism, any of those conditions will cause that, okay? So the two factors that determine cardiac output, stroke volume and heart rate. Okay, so what is the cardiac output at rest and during exercise, and the cardiac reserve if the heart rate is 75 beats per minute and stroke volume is 70 milliliters? You multiply those two. And so that's when how you will get the cardiac output. Distinguish the effect of a positive chronotropic agent from that of a, so a positive chronotropic agent will increase the heart rate, a negative chronotropic agent will decrease the heart rate. Examples: positive chronotropic agent, adrenaline; negative chronotropic agent, um, calcium channel blockers or beta blockers. What's the atrial reflex? The greater the amount of blood returning to the atria, the harder it will contract, okay? Which of the following increases stroke volume? Increased venous return? Yes, that will increase stroke volume. Increased calcium ions in sarcoplasm? Yes, that will increase stroke volume. Increased afterload? No. That means high blood pressure, your stroke volume would be lower actually. If both heart rate and stroke volume increase, does cardiac output stay the same, increase, or stay the same? Because both of them are increasing. Thus, is the relationship between the two variables in cardiac output direct or inverse? So what would that be? Direct, as we can see here, right? If both heart rate and stroke volume increase at the same time, your cardiac output basically um, will actually increase. It will increase. So yeah, direct. Both heart rate and stroke volume increasing, your cardiac output increases. Okay, so the last few slides are about the formation, the embryological formation of the heart. So I'm just going to skim over those slides here. This is the formation of the heart when you were a 22-day-old embryo, right? You can see the primitive ventricle and the primitive atria forming here. Uh, okay, the only important structure during the development of the heart that I would like you guys to focus on is this window that is connecting the right side of the heart with the left side. Remember the foramen ovale. This allows for the right side uh, heart blood to be mixed with the left side. And this is not a problem at all when you're a fetus because you're not even breathing on your own. You're getting pre-oxygenated blood from your mother's umbilical vein directly into your right atrium. It passes directly to your left atrium, then to the left ventricle, and all the way to the rest of your body. So the foramen ovale is open in a fetus, okay? But by the time that you're born, actually at the time that you're born, when you cry, when you take that first gulp of breath, these pressure changes cause this window to snap shut for good, hopefully. And so all you have after that is a scar called the fossa ovalis. That is just a reminder of what was once an open window called the foramen ovale, okay? All right. So these are some congenital heart defects, people born with holes in their heart, if you will. Okay, when you say that, a hole in the heart can mean a number of different things, such as an ASD for atrial septal defect. The two atria are not completely uh, separated. They are communicating together so the blood can move from the right side of the heart to the left side. The good blood is mixing with the bad blood, okay? Or ventricular septal defect, VSD. So the ventricles are now not completely separated. Or tetralogy of Fallot. Tetra means four things. So what four abnormalities do you see with tetralogy of Fallot? Uh, Ventricular septal defect, narrow pulmonary trunk, aorta overlapping ventricle, and enlargement of the right ventricle, meaning heart failure. Okay. How will you fix something like this? Surgery is the only option. You have to surgically separate the two sides of the heart. What would be the path of blood flow through the heart if the foramen ovale did not close shortly after birth? The deoxygenated blood will mix with the oxygenated blood. The right side of the heart would be mixing up with the left side. Okay. All right, so we're done here with our chapter 19. Let me quickly take a look here at some of the emails that are poured in, just making sure I'm not missing anything. Okay, looks good there. So let's go ahead and start with our next chapter here, which has to do with blood vessels, chapter 20, as we see. So let's go ahead and start right away. All right, so we have three types of blood vessels, right? In humans, and what those three types are arteries, veins, and capillaries. We talked about that before. What are arteries? Muscular blood vessels. They're also called the pressure vessels because they are connected directly to the heart, right? It starts with the aorta, which is the main artery of the body connected directly to your left atrium. So they are under a lot of pressure, and their function is to take blood away from the heart to supply oxygenated blood to the rest of the body. But there are some exceptions, a couple of exceptions where arteries actually carry deoxygenated blood. Hopefully remember what those two exceptions are. Your pulmonary trunk and your umbilical cord, right? So the two exceptions to arterial oxygenated flow. All right. Capillaries, these are the finest, the tiniest of all, very fragile, only one cell thick, and they are the exchange vessels, which means they allow for nutrients and blood and gases to pass in and out of cells, right? So they allow for exchange. Veins are also called your capacitance vessels because veins are less muscular than the arteries. They carry blood uh, towards the heart from the rest of the body to back to the heart, and they are not under as much pressure as the arteries, okay? Right, so when you look at these blood vessels, the arteries and the veins, each has three different layers or membranes surrounding them, what are called the tunics. Tunica externa on the very outside, tunica media in the middle, and tunica intima on the very inside, okay? So the tunica intima, let's start with that. It is the innermost layer, and it's made up of simple squamous type of epithelium, okay? Also with areolar connective tissue interspersed there. Then comes the tunica media. The middle layer is muscular. That is where you have the smooth muscle located at. And the smooth muscle of these blood vessel walls is responsible for causing vasoconstriction. When these smooth muscles, excuse me, contract, they cause your blood vessels to shut down, okay? And when they relax or vasodilation, they open up your blood vessels, okay? And then you have the tunica externa on the very outside. It's made up of collagen, the tough protein called collagen, and some areolar connective tissue as well. Now, the tunica externa is also supplied by some other blood vessels called the vasa vasorum, which are the small arteries that, so the arteries not only supply other body tissues, but they supply themselves again using vasa vasorum, as you can see here. So here's your artery and here's your vein. What are some differences? First up, similarities. They have the same three layers. An innermost tunica intima, right? Made up of simple squamous epithelium. Then the muscular tunica media, much more muscular in the artery as compared to the vein. And then the tunica externa on the outside, which is full of collagen fibers. All right, so what are some differences that you see between arteries and veins? So these colors are just to tell you a vein is not technically blue, even though they look bluish green. That's simply because it's an interplay of your skin pigment, your skin color, the light, and the red color of the blood. They're not really red or blue in color. We have talked blue or green in color. We have talked about that before, unless you're a horseshoe crab again, okay? So all this is telling you is that it's primarily deoxygenated blood that flows through the veins, okay? So the first difference is the arteries are much more muscular. The tunica media is more muscular. You can see it here. The tunica media is not as muscular. What's the second difference? Look at those structures, flaps or valves. Veins have valves, and these are unidirectional valves. Again, they only allow for blood to move in one direction, which is towards the heart. So the blood only goes this way. When it tries to return back, the flaps close, the valves close back, and so they keep pushing the blood in one direction, which is up towards the heart. What happens when your venous valves fail? You get something called varicose veins. When your veins become big and dilated, like almost like worms or snakes, and they become painful and unsightly and all that. So that's varicose veins. That's a failure of your venous valves here, okay? Now here are the capillaries. And the capillaries are exchange blood vessels. See how the arterial blood, which is rich in oxygen, goes through the capillaries. The capillaries give oxygen to the surrounding blood vessels, and then they turn this bluish color, which simply means that this is deoxygenated blood, and then they go back to the vein. So from the arteries to the capillaries to the vein. This is a whole circuit of blood flow. And then you also have these tiny arteries called vasa vasorum, which are supplying the arteries and the veins themselves, all right? So these are the structures that you will see in these types of blood vessels as seen here. So remember their similarities and the differences, okay? All right, so different types of arteries and veins. Elastic artery, these are the largest and the most muscular, like the aorta itself, this type. Then the muscular arteries, a little smaller and a little less muscular, like your brachial artery in the arm and so on. And then the smallest of arteries called the arterioles, right here, okay? Similarly with veins, large veins, like your superior and inferior vena cava, small to middle-sized, medium-sized veins, and then the very smallest venules. And then, of course, the capillaries are the finest of all, as you can see here. So the elastic or the conducting arteries are the largest, thickest, most muscular. Examples are these: aorta, pulmonary trunk, common carotid, all the major arteries that supply your vital organs. Then you have the muscular arteries, which are a little smaller and a little less muscular, okay, like your brachial artery and your coronary arteries. Then the arterioles, which are the smallest of all, no greater than 0.3 to 10 micrometers to 0.3 millimeters in diameter, as you can see here. Okay, so there, that's your muscular artery, elastic artery, lots of muscle and elastic tissue. Then your muscular artery, a lot of muscle, not that elastic though. And then the smallest of all, arterioles. This is under the microscope again. This is what they would look like there. All right, atherosclerosis is a major cause of heart attacks and cardiac disease. Atherosclerosis comes from the word atheroma and sclerosis. Atheroma is a fatty plaque, too much cholesterol, too much animal fats. If you're eating in your diet, that forms atheromas, balls of fat, okay? Sclerosis means stiffening or hardening of the arteries. So your arteries are getting stiff and hard because of these fatty plaques clinging to your arterial walls because you won't quit on your burgers and your steaks, and that's the only food or the predominant type of food that you consume, animal food, okay? So so with age, what happens is, and if you're a smoker, that's like rubbing salt into injury. That's a double insult. So these atheromas, they become thicker and thicker, and they get big to this point where they cause a complete blockage of your coronary arteries. And if, especially if it's in your widowmaker artery, then that's curtains out. Uh, that's lights out for you at that point. So so this is what happens. It's constant injury and inflammation because of too much animal fat clinging to your coronary arterial walls. And that's why it's important to go on a Mediterranean diet, primarily a plant-based diet, and non-saturated, unsaturated fats and physical activity, okay? So hypercholesterolemia, as you can see, the major cause of atherosclerosis, right? That's too much animal fat in your diet. Males more affected, so sex itself is a risk factor. And again, smoking and hypertension or high blood pressure, that's like um, insult to injury, right? So that's a double insult, as I mentioned. Treatment, we have a couple of options here: angioplasty or a cabbage. which is a mnemonic for coronary artery bypass grafting. So what is angioplasty? You take a needle with an inflatable balloon at the tip. You insert that needle through a patient's brachial artery, and then you insert it all the way through. All the while, you're visualizing this process on a computer screen using ultrasonic technology and ultrasound. And so this needle reaches all the way into your blocked artery, coronary artery, at which point you will inflate the balloon. The balloon inflates, which opens up the artery, right? And then you deflate the balloon, and then you pull the needle back. So what you have done in essence here is you have used this ballooning procedure to open up a blocked artery. And you would also like to put a stent in there at that point. A stent is a mesh. It's like a network, and sometimes the stent is coated with anticoagulant drugs like warfarin or heparin. So this narrowing of the artery does not happen again. So you might want to put in a stent while you are at it during angioplasty. Okay, so that's one way of doing. Of treating someone with atherosclerosis and atherosclerosis induced uh, coronary artery disease. The other one is CABG, right? Coronary artery bypass grafting. What happens here? So what happens here is basically you have the coronary artery is blocked and you have to remove this blockage so that the blood can flow back to the heart. What you do is you take out a vein from the leg of this person. In the vein which is most commonly used for this grafting purpose is what is called the great saphenous vein. The great saphenous vein that runs the entire length of your leg from your thigh down to your foot. So you take this vein, and so let's say you have a blockage at this point in your blood vessel, right? So you're going to take this vein, you're going to attach, graft one part of the vein to this part of the coronary artery, and you're going to attach the other end here. So what you have done here is you have provided a detour, a bypass to the blood supply. So the blood can now flow through this detour and bypass the blockage here, okay? And so now the name makes sense. Coronary artery bypass grafting, CABG. It's done on the coronary artery. You are bypassing the obstruction here and you're grafting a vein, okay? What kinds of patients would benefit from angioplasty versus what kinds of patients would benefit from a CABG? What do you think? First up, angioplasty is an outpatient procedure. Okay, so it can be done in under 30 minutes. It does not require any anesthesia, any serious open heart surgery or anything. So younger patients, patients who want to be mobile, patients who have limited heart disease will benefit from angioplasty. How about CABG? Older patients, patients who have like extensive coronary artery disease, uh, they would definitely be good candidates uh, for a coronary artery bypass grafting. The thing with angioplasty is, unfortunately, in about 40 to 50% of cases, this blockage will recur. Okay, that's a problem. With CABG, now you have provided a bypass, so this is more viable in the long term. Okay, so angioplasty is outpatient department fast, but the recurrence rate is very high. So what is an aneurysm? That's simply when your artery blows, it bursts. And aneurysm is basically a ballooning of your artery. Here's the normal artery, and here there is like a weakness, like a ballooning out of the artery. Most of the aneurysms are congenital. You're born with them, you don't even know them that you have an aneurysm. Unfortunately, the only time people realize that you had a congenital aneurysm is when you blow an artery in your brain and have a stroke or even die or something like that. And they perform an autopsy and they found, oh, okay, so there was a weakness in one of the cerebral arteries. That's an aneurysm. But as you grow older, aging, your risk of getting an aneurysm and getting complications from it, it goes higher, right? You age, your arteries get more stiff, your blood pressure tends to rise as well as you get older. If you exercise with heavy weights, if you drink a lot of coffee, anything, or smokers, drinking, anything that will give you high blood pressure increases your risk for developing an aneurysm, okay? If you like have constipation and you sit on the pot for long periods of time, and uh, that entails a great increase in pressure too. So if you have an aneurysm, that might put you at risk as well. So risk factors, risks for aneurysm. Okay. If caught in time, you can surgically First of all, you have to control your blood pressure with antihypertensive, anti-blood pressure medications, but you can also surgically fix the aneurysms as well, okay? All right, so here is a capillary, the finest of all blood vessels. As you can see, it has a basement membrane here, and you can see the red blood cells squeezing through here, through your capillaries, okay? All right, so capillaries are of three different types, as you can see here. What are called continuous capillaries, fenestrated capillaries, and what are called sinusoids. All right, let's take a look at each. Continuous capillaries have a well-defined basement membrane, as you can see. So the red blood cells cannot pour out, okay? A nice, tight basement membrane is what you see here. So these types of capillaries are found in your muscles, skin, lungs, and central nervous system, places where you do not need a lot of exchange, a blood flow in and out, okay? The second type is fenestrated capillaries, and it's called that because fenestrations means these pores. You see these punched out holes here. This is what fenestrated capillaries look like. And these holes, they allow for proteins to spill in and out of the capillary at all times. So therefore, these types of capillaries predominate where you have a lot of blood exchange, such as in your intestines, because you're absorbing food into your blood. Also in your kidneys, because there you're filtering out blood to make urine. So those are the two places where there's a lot of fenestrated capillaries. The leakiest of all, um, though, are these sinusoids. They're so leaky that they don't even have a proper basement membrane. It's all like in tatters, you can see rags, right? All broken. So blood can freely pour in and out. So sinusoids predominate in some of the bloodiest regions of your body where there's a lot of blood flow going in and out, like your red bone marrow, spleen, and some endocrine glands. Okay, so that is where these types of sinusoids will predominate. So remember the three places, the three types of capillaries, and where you will find each type. All right, so what you're seeing here is an arteriole, here's a venuole, and the capillaries which are connecting the artery with the vein. And look at the color change, right? This is fresh oxygenated blood. It flows through the capillaries, it loses the oxygen to the surrounding tissues. Look at the color changes becoming darker. Now purple and different shades of blue, and then finally deoxygenated blood back to the vein. So it can be taken back to the heart for further oxygenation, okay? So you can see here. Now one thing, you see these rings of muscle, smooth muscle, are called sphincters. So when you need to increase blood supply to your tissue, such as when you're exercising, these sphincters open up. So a lot of blood starts flowing to your tissues to supply them with oxygen. But when you do not need so much blood going to your tissue, such as when you're cold and when you're trying to conserve energy, then these sphincters contract. And you see all of the blood supply has been cut off. It's like your plumbing system. When you need a lot of plumbing, blood going to a certain area, the capillaries dilate, the sphincters open up, the valves open up, if you will. And when you don't need that much blood, the valves close like this. All right, so there you have the location of blood in the different blood vessels. So look at that. Most of your blood is where? In your veins. 55% of your blood is contained within your systemic veins. About 10% is in the arteries. The lowest amount of blood is in your capillaries, okay? And in your circulation, your lungs have the most blood at any given time. 18% of your blood is in your lung circulation, pulmonary circulation. Makes sense. Why there? Because you're picking up oxygen from the lungs. That's where the blood needs to be to get oxygenated. These are the breathing organs, the oxygenating chambers of the heart, of the human body. And then heart has 12% of blood. Okay. So veins are your blood reservoirs. Veins store blood. And that's why you need to be moving a whole lot, because you don't want all of this blood stagnating in your veins of the lower legs, especially if you're overweight and inactive, right? Because if this blood stays stagnant, not moving in your lower veins, then you can get blood clots, something called DVT, for deep vein thrombosis. This is a major risk factor in hospitalized patients too. As a nurse, you're required to turn the patients on their sides, those who are immobile, right, in hospital beds. If nothing else, then you have to put compression stockings on them, right? And this is something called DVT prophylaxis, which means trying to prevent deep vein thrombosis. And you can do it with compression stockings. These are like tight-fitting stockings or socks, which basically squeeze or milk your legs at regular intervals, right? So they keep the blood moving in these immobile patients in hospitals. Compression stockings, uh, periodic massaging the legs, all right, they will also uh, prevent DVT, or putting them on anticoagulants, drugs that prevent blood clotting, like uh, anticoagulants like warfarin and like heparin and warfarin, right? Clot busters, Coumadin, which is warfarin basically. So that becomes important. Okay, anastomosis, what does that term mean? That term means where when two arteries, they join up together, or two veins join up together, okay? And there's some examples of arterial and venous anastomoses, as you can see here. Why are these important? In organs where there's limited blood supply, such as your brain, excuse me, and your heart. So if one of the main arteries is blocked, there's always a detour, another artery which can pick up the slack, if you will. So that's where the arterial anastomosis become important. Same with venous anastomosis. If the blood flow back from the heart is blocked at any point, a neighboring blood vessel can take up the slack and take the traffic from there. Uh, AV anastomosis is when an artery and a vein are joined together directly, all right? And you'll see those in places like your fingers and toes and ears. Why? We saw an Arctic front a couple of weeks back, right? We saw some freezing temperatures. If you were out in those temperatures, what would happen? Your fingers and your toes and your ears, they are the first ones to get a frostbite. Why? Because the blood flow from these areas is diverted directly from your arteries into your veins, and that warmth and heat of the blood is carried to your vital organs, to your brain and your heart and your liver, rather than your fingers and toes and stuff. So, because they are expendable. If push comes to shove, it's much easier to get rid of your fingers and toes and ears and penises. And that happens, those are the areas that get amputated, that get frostbitten, rather than your vital organs like your brain and your heart and your liver. So that's where you find the AV anastomosis. Doctors will also create artificial AV anastomosis in dialysis patients, right? You've seen those in dialysis patients. They will take blood from an artery, clarify it, cleanse it out in a dialyzing machine, and then send it back directly to a vein. So what are three differences in an anatomic structure between arteries and veins? Arteries are more muscular, veins are less muscular. Veins have valves, arteries do not have valves. Veins have a thicker tunica externa, arteries have a thinner tunica externa. What changes are seen in the composition of the tunic wall of arteries as they branch into smaller and smaller vessels? The tunics become thinner and less muscular. What type of capillary is the most permeable? Sinusoids. Where are they found? Red bone marrow, some endocrine glands in the spleen. How does a vein serve as a blood reservoir? Since it's like stretchy, they can accommodate a lot of blood. About 55% of blood by volume is in your veins. How does each of the various alternative blood vessel pathway differ from the simple pathway? So you can have anastomosis, arterial anastomosis, venous anastomosis, AV anastomosis. Okay, next up, what are we seeing here is uh, the cross-sectional area of a blood vessel and the speed or velocity of blood flow. What does that show you here? Look at that. Uh, the greatest cross-sectional area is in your uh, capillaries. Why? Because capillaries are the most abundant, the most numerous of all blood vessels are your capillaries. So when you cut each of your capillaries and spread them out, they have the greatest cross-sectional area. The greater the cross-sectional area of a blood vessel, the slower the velocity of blood flow. And that's what we see. The greater the surface area, such as in capillaries, the slower the flow of blood is, okay? Look at the blood flow velocity, it decreases. Uh, and as you see in the arteries, the blood flow is still pretty impressive because the arteries are being pumped directly. They're connected directly to the heart. And then in the veins is when the blood vessel slows down, the blood velocity slows down and then slowly starts to pick up again, all right? In which type of vessel is blood flow the slowest? In your capillaries, okay? And why is that the case? Because your capillaries have the greatest surface area, cross-sectional area. Again, the greater the cross-sectional area, the slower the flow of blood. All right, so how does stuff move in and out of blood to your different organs? Diffusion first. Diffusion is simple, right? Things moving from uh, high concentration to low concentration areas. So things like gases, oxygen, carbon dioxide, they diffuse simply. The other way of moving stuff is something called vesicular transport, right? So what does that mean? Uh, Stuff is carried out by means of exocytosis or penocytosis, which means what? Actual bubbles or vesicles transport things like proteins from in and out of your blood vessels, all right? Okay. Or bulk flow. Bulk flow is substances, fluids simply move down an area just based on pressure, like hydrostatic pressure, okay? So that's bulk flow. All right, so here we are looking at whether fluid will move out of a blood vessel or into a blood vessel, okay? So as you can see here, there's quite a number of forces at work, at least four of them, which are net hydrostatic pressure, net colloid osmotic pressure, okay? And then, um, so these two basically add up to your net filtration pressure. So what does this actually mean? Okay, so here, what is your hydrostatic pressure first? Hydrostatic pressure is simply the pressure of a fluid moving through an object. It's like when you take a water balloon, when you fill up the balloon with water, that's hydrostatic pressure. When you get an erection in the penis or the clitoris, that's hydrostatic pressure, a lot of blood flowing to the organ, not so much blood flowing out. So there's a back of blood and you get an erect penis or an erect clitoris. Same with the balloon. So this is hydrostatic pressure, the simple pressure of blood flowing through through an organ, through a blood vessel, okay? On top of that, you also have something called uh, colloid osmotic pressure, and that is the pressure of the proteins sucking the fluid towards itself, okay? That's colloid osmotic pressure, the pressure of your plasma proteins, your blood proteins sucking the fluid towards themselves. That's your colloid osmotic pressure. All right, so let's take a look at the arterial side, the red side here. What happens here? Remember, the blood pressure is high because the arteries are directly connected to the heart. So blood pressure is high, so they have a high hydrostatic pressure, which is pushing the fluid out. This is pushing the fluid out, the hydrostatic pressure, right? At the same time, there are some uh, plasma proteins within the blood here as well, and that is trying to suck the fluid back in. Who wins? Who wins? Depends on the values. What is the value of your hydrostatic pressure, net hydrostatic pressure? 35 millimeters of mercury, okay? What is your sucking in, vacuuming pressure, the net colloid osmotic pressure here? Only 21 millimeters of mercury. So who wins? Hydrostatic pressure, which means the fluid moves out at the arterial end, okay? So you have a net filtration pressure. If you subtract this from this, of 14 millimeters of mercury, which is pushing the fluid out. Okay, what happens at the venous end? So at the venous end, let's take a look at the net hydrostatic pressure. By the time your blood gets here, the blood pressure drops on your venous side. So you only have 16 millimeters of mercury of your net hydrostatic pressure here. And how about your colloid osmotic pressure, the pressure, the sucking in pressure of the plasma proteins contained here? It's about 21 millimeters of mercury. So when you subtract 16 from 21 millimeters of mercury, the net filtration pressure is a -5, which means the fluid is being sucked in. So the arterial end is pushing fluid out of the blood vessel. The venous end is sucking the fluid back in. It's a balance. But this balance can be disrupted, such as if you have liver disease. If you have liver disease, what happens then? There's not much plasma proteins being produced in the liver, so not much protein here. Fluid starts to pour out in liver disease. And that's why if you have someone with hepatic failure, alcoholic hepatitis, hepatitis B, hepatitis C, infectious liver failure, they have big bellies. Fluid is pouring out, something called ascites because of this. So let's call it uh, the mechanics of ascites, right? Which means decreased osmotic colloid pressure, pressure in liver failure patients. Okay, that's why they get these distended bellies and a lot of fluid in their abdomen, basically. So you also have something called the lymphatic system. Okay, so these lymph vessels, they also carry some of the fluid back to the heart. So 15% of your fluid, which is not reabsorbed by the capillaries, is actually returned to your venous circulation by means of your lymphatic vessels. Okay, so what substances are transported by diffusion? Oxygen, carbon dioxide, water. Which substances leave the capillaries by vesicular transport? Small proteins. What is the difference between hydrostatic pressure and osmotic pressure? Hydrostatic pressure is the pressure of fluid flowing through a hollow object. Osmotic pressure is the sucking pressure of protein on that fluid. How does the hydrostatic pressure change from the arterial to the venous end of a capillary? It decreases. Do you see similar changes in colloid osmotic pressure? Uh, we do. The colloid osmotic actually no, the colloid osmotic pressure stays the same from the arterial to the venous end because proteins don't pour out generally. Which two pressures have the largest values? Hydrostatic pressure and colloid osmotic pressure. Okay. Um, if these lymph vessels were non-functional, what would happen to the amount of interstitial fluid around the capillary bed? It will increase because more fluid will be accumulating, will not be carried back to the heart. Okay, degree of vascularization, how much blood flow goes to a certain part of your body. It depends on what body part are you talking about, such as your lungs, heart, liver, brain. They are highly vascular. A lot of blood goes there. They are your vital organs. But if you're talking about things like your tendons, ligaments, cornea, lens of the eye, they are avascular. Not much blood flow goes there. And that's why they say why it's better to break a bone than to get a sprain, right? Bones are bloody organs. A lot of blood there, so bones heal. Fractures heal faster. A sprain is a tear in your ligament, which is avascular, not much blood supply. It will take forever to heal, okay? Angiogenesis, forming new blood vessels. When do you form new blood vessels? Such as when you start exercising, you get big muscles. So a lot of those arteries divert their blood supply to your muscles. They supply the muscles, angiogenesis. Or if you become lazy and eat a lot of foods, extra calories, you become fat, then this blood is diverted away from your muscles to your fat. They start feeding your fat tissue, which is not a good thing because if you feed your fat tissue, fat is an inflammatory substance. So it will cause release of inflammatory chemicals in your system, and this chronic inflammation will give rise to things like diabetes, heart disease, and cancers. So fat is inflammatory, something to remember. You don't want your blood vessels feeding blood to your fat tissue, rather to your skeletal tissue, okay, to your muscle tissue. Regression. If you stop working out, your blood vessels regress. Or if you lose weight, lose fat, then your blood vessels to the fat regress. So it's always going on. Your body is always shifting depending on how healthy you are at any given time. What is your exercise pattern versus your eating patterns, okay? Tumor angiogenesis. So your cancer cells, they have this uncanny ability to steal all the blood from the surrounding tissues, right? So tumor angiogenesis is when your cancer cells release chemicals that cause all of the blood vessels to grow towards them, to feed them. That's what your cancer cells want. They want to be fed the blood at the expense of the normal tissue. So now we are looking at ways to stop this from happening, from starving your cancer cells of this blood, all right? So if you can do that, then you can basically starve your cancer cells. And that's why you should be eating a little less. Overeating will also feed your cancer cells, okay? But if you're maintaining a healthy weight and watching the calories that you eat, your cancer cells don't have much nutrition to go off of. So something to remember, okay? All right, so what are some substances which are vasodilators versus vasoconstrictors? Vasodilators, they cause your blood vessels to dilate, all right, such as what? What causes vasodilation? An accumulation of carbon dioxide or hydrogen ions, acidity, they cause vasodilation. What causes vasoconstriction? Your blood vessels to constrict? Blood loss. If you're losing blood, that will cause reflexive vasoconstriction, okay? So autoregulation, your blood vessels are always regulating themselves subconsciously. When you start exercising, the blood vessels dilate to your heart and to your skeletal muscle. When you are cold, vasoconstriction happens in your skin. So your skin becomes pale, right? Pale or bluish because all the blood is diverted away from the skin again to your critical organs. So autoregulation, homeostasis is always going on. Reactive hyperemia, we have all experienced it. Let's say we're out in the cold blizzard conditions, had layers and layers of clothing on, and then you walk back into a heated room and you all of a sudden you start sweating and you feel extra hot and you start flushing and blushing and you take off all your clothes. That is reactive hyperemia. There was intense vasoconstriction, in your skin, diverting the blood away from the skin to your vital organs. And then all of a sudden, there was this, when you walked into a hot environment, intense vasodilation. All of this blood started flowing back to your skin and you started sweating like crazy. All right, so inflammation, what is it? Inflammation is four things: tumor, dolor, uh, calor, and rubor. Redness, heat, pain or itching, and swelling. Okay, four things, four Latin terms for these four things. That's inflammation. So acute inflammation is good. Inflammation is your body's response to any insult, any injury, or an insect bite, or any other kind of injury. Chronic inflammation, if it goes on for long periods of time, such as people who eat a lot of fat, have a lot of belly fat, chronic inflammation is not good. Chronic inflammation will give rise to, again, unhealthy eating patterns, obesity, too much body weight. That causes chronic inflammation in your system. Chronic inflammation will lead to coronary heart disease, or to cancers, to diabetes, all kinds of things. Okay, uh, so something to keep in mind. So in what ways is angiogenesis stimulated in skeletal muscle? When you start exercising, you get bigger muscles. Angiogenesis is stimulated, more blood flows to your muscles. In adipose tissue, fat tissue, when you put on a lot of fat, so the blood flow is diverted away to the fat tissue now, which is not a good thing, by the way. Explain the myogenic response to an increase in systemic blood pressure. When the blood pressure increases, right, a lot of blood going through a blood vessel, it reflexively vasoconstricts to bring the blood pressure down to normal. What relationship exists between metabolic activity and local blood flow? The more active you are, the more the local blood flow would be. How is local blood flow dependent on total blood flow? So again, the more physically active you are, the better the blood flow to all different parts of the body. Okay, so blood pressure, what is it? There's two values: systolic blood pressure and diastolic blood pressure. What is systolic blood pressure? The blood pressure in your arteries when your heart is maximally contracted, okay? In a healthy value, the optimal value is less than 120 millimeters of mercury. You use millimeters of mercury to measure your blood pressure. Ideally, your systolic blood pressure should be less than or equal to 120. Diastolic blood pressure is when the blood pressure in your blood vessels, in your arteries, when your heart is maximally relaxed or contracted or diastole. And that should be 80 or less millimeters of mercury. Okay, so your optimal blood pressure should be less than 120 over 80. Okay, pulse pressure is the difference between your upper reading and the lower reading, between your diastolic and your systolic blood read. So if you have 120 over 80, what's the difference? 40 millimeters of mercury. That's your pulse pressure, okay? Uh, this pulse pressure tends to become less and less as you age. And also if you're not eating healthy and not exercising. Because of atherosclerosis and arteriosclerosis, which again means stiffening of the arteries that happens with age and unhealthy lifestyles, your pulse pressure decreases, which means your cardiac reserve is going down. So your cardiovascular system is not in the best of shapes at that point. A pulse, you can feel the pulse here, the radial pulse. You can check the pulse in the carotid artery, right? The pulse is the throbbing of the arterial wall, and that gives you an idea of what your heart rate is. So here you can see someone taking blood pressure. Ideally, it should be 120 over 80, as you can see in this person. Okay. Blood pressure is the highest in your large arteries like the aorta, and it goes down as you get to down to your capillaries, and it's the lowest in your veins because the veins are the farthest away, and that's why your veins have valves to push the blood back uh, to the heart, right? So then how do you calculate something called your mean arterial pressure? Here is the formula: mean arterial pressure equals your diastolic pressure plus 1/3 of your pulse pressure. So if your diastolic pressure is 80, then 80 plus 1/3 of your pulse pressure, that would be your mean arterial pressure. And it gives you a general idea of how well your perfusion is, like how much of your blood is going to different parts of your body, okay? If it's less than 60, that's insufficient blood flow. Why might you have a blood flow less than 60? Maybe you're losing blood because you got shot or cut or whatever. Maybe you have a ruptured organ on the inside or something like that, okay? So cerebral edema is when fluid accumulates around your brain. That's what it literally means, fluid in the brain. And that can happen if your blood pressure is so high, like greater than 160 millimeters of mercury. If your mean arterial pressure is that high, then you can have cerebral edema. And that is dangerous. You have to relieve this fluid pressure on your brain, okay? So keep your blood pressure low, prevent hypertension. The best way to prevent hypertension, eat healthy, exercise, manage stress. Again, the same three things. So venous return, what are the factors that help your blood flow back to the heart, right? Uh, Exercising. So here, when you exercise your muscles, those muscles squeeze the blood back to the heart, right? That's one way. The other way of getting more blood to get back to your heart is by simply breathing. When you breathe in, the diaphragm moves down and your chest expands, so that sucks the blood back to your heart. And when you breathe out, then the blood is moved out of the heart. So back to the heart when you breathe in, pushed out of the heart when you breathe out. So this is kind of like a cardiac massage by breathing. When you exercise, you breathe faster and harder as well. So that is also helping milk all of this fluid, this blood, squeeze it back through the veins to your heart. So exercise is good, whichever way you look at it. Because if you don't exercise, then you're at risk for things like this, DVT, deep vein thrombosis. A thrombus is a clot in a vein, right? Um, and if you have it in your calf, which is the most common site of a DVT, deep vein thrombosis, you might have these things like pain, tenderness, hotness, inflammation in your lower leg, or you might have no risk factor, which is even more dangerous. You don't even know. Someone who was sitting for a long period of time, they developed this DVT, and then all of a sudden they got up and started moving about. Now, as the blood started to flow back when they're moving around, this will break the clot from the wall of your lower vein, and now this is a clot on wheels. It's traveling. This is called a embolus, and it can come and it can block your pulmonary vasculature. That's when you get a pulmonary embolism. This could be dangerous, okay? Because of course, if there's a blockage in your lungs, your blood is not being oxygenated. All right, pulmonary embolism. Varicose veins, another condition commonly seen in during pregnancy. People who become overweight gain a lot of weight very fast. People who are not physically active, all of them, or people who stand for long periods of time upright and they're overweight or obese as well. Varicose veins is a failure of your venous valves. So all of this blood falls back and accumulates in your lower legs. This, of course, will also put you at high risk for DVT, for developing deep vein thrombosis as well. So these are some of the risk factors, all right? So prevent them, basically. Hemorrhoids, same thing. Varicose veins, only they are in the anal region and not in your legs. That's what hemorrhoids are, okay? So sitting on parts for long periods of time and being constipated, they put you at risk for developing hemorrhoids. Hemorrhoids can cause a lot of itching and pain in the anal region, right? Uh, so for example, I was in the habit of reading books and novels while sitting on the pot till I developed a case of first degree hemorrhoids. And that's when I just said no to all of that. And so I just do my business, whatever needs to be done, and get out of the bathroom. All right. So yeah, that is what gave me hemorrhoids, basically, books in the bathroom. Okay. All right, what else? So circulatory shock. This happens when not enough blood is being returned back to your heart, okay? And what can cause it? Number of things. Actual clots in your blood vessels or in your veins, DVT, will cause a circulatory shock. Okay, if you're having a serious allergy, that will cause your blood vessels, your veins and arteries to become leaky and capillaries to become leaky, so a lot of fluid pours out, and that can lead you to circulatory shock. Hemorrhage, being shot or stabbed or cut or something. All of these are risk factors for developing circulatory shock, not enough blood returning back to the heart, okay? So resistance to your blood flow. What increases the resistance to your blood flow returning to your heart or going away from your heart? High blood pressure. That's resistance. Okay. Uh, Thicker blood. When your blood viscosity increases, who has thicker blood? People who take steroids, blood dopers, blood doping. That will give you high viscosity. People who are dehydrated, they also have thicker blood. So prevent dehydration. Don't take steroids, don't do blood doping, because that will cause resistance to your blood flow as well. And the vessel length, the longer the length of the vessel, the greater the resistance to blood flow. So when, for example, when you become fat, when you gain a lot of weight, there's a lot of fat tissue, so the blood vessels are stretched, and so that increases your blood pressure as well. The fatter the person, the greater the blood pressure, again, because of the stretching and the increase in the vessel length, as you can see here. 55-year-old female has an arterial blood pressure of 155/95. What are her pulse pressure? 155 minus 95. That would be her pulse pressure. Use the formula there. And same for mean arterial pressure. What is the physiologic significance of capillary blood pressure? That determines how much exchange of nutrients and oxygen is going on. How is the small pressure gradient in veins overcome? By means of valves. The veins have valves that push the blood in one direction towards the heart. How is the pressure gradient to move blood through the systemic circulation calculated? Okay, refer back to the formula. What is the significance of this pressure gradient to make sure that there's enough blood pressure to move blood throughout your vasculature? How is resistance defined? Resistance to blood flow, obstruction to blood flow, simply. What are the three factors that alter resistance? The viscosity or the thickness of your blood, the diameter of the blood vessel, and the length of the blood vessel. In general, would you predict a higher blood pressure, lower blood pressure, or normal blood pressure individuals with sustained increased resistance? Higher blood pressure, no question about that. So what controls your blood pressure? Your cardiovascular center, which is found in your brain stem, in a region called the medulla oblongata. It has two centers, a cardiac center and a vasomotor center. The cardiac center controls your heart rate, your beat, your pulse. The vasomotor center controls vasoconstriction versus vasodilation. Both of them are being controlled by your brain stem here, all right? The cardiac center has two centers, a cardioacceleratory center, which accelerates the heart. It's a positive chronotropic area, right? It increases the heart rate by firing more impulses to your SA node. And then a cardioinhibitory center, which slows down the heart by releasing, um, uh, activating your vagus nerve, which is your parasympathetic rest and digest nerve. So those two. Vasomotor center, again, will either cause vasoconstriction or vasodilation, okay? All right. Baroreceptors, they respond to the stretch. Baro means pressure. They respond to stretch of your blood vessels, okay? And you have two of them, what are called the aortic baroreceptors, okay? And they're located within your aorta, and then also the carotid sinus baroreceptors, and they are located in the walls of your carotid arteries. And so they are keeping a tab on your blood pressure to your heart and to your brain. If there's too much blood flowing to the heart or the brain, these vasoreceptors will signal your brain stem to take it easy, to lower the, slow down the heart, right? So that's what we are looking at here in this picture. So just like your baroreceptors, you also have chemoreceptors, and they respond to chemicals, okay? Again, you have the aortic chemoreceptors located in the aorta and the carotid chemoreceptors located in the carotid blood vessels. And they respond to not pressure this time, because they're not baroreceptors, but to chemicals like acidity, like low pH or high carbon dioxide or low oxygen. And so they tell your body when you have low oxygen or too much acidity, and so they will cause vasodilation in those areas so that more blood can flow and wash out the acid and supply oxygen to that area. So then this is another very powerful controller of your blood pressure, the renin-angiotensin system, or the RAS. How does that work, the renin-angiotensin system? So it starts with a protein called angiotensinogen, which is made by your liver, angiotensinogen. At the same time, your kidneys release a hormone called renin, as you can see here, all right? And renin is released in response to low blood pressure, when your blood pressure goes down because you're bleeding or whatever the reason is. So what renin does from your kidneys, it converts this liver protein called angiotensinogen into angiotensin 1, okay? Then you have another enzyme called angiotensin converting enzyme, or ACE, which converts angiotensin 1, this, into angiotensin 2. Angiotensin 2 is a very potent, powerful vasoconstrictor. This will increase your blood pressure, angiotensin 2. All right? So angiotensin 2 raises blood pressure because of vasoconstriction. It also makes you thirsty, so you drink a lot of water, fluid, and that will also increase your blood pressure, as you can see here. So there, angiotensinogen released from the liver, renin released from your kidneys. Renin converts angiotensinogen into angiotensin 1, and then the angiotensin converting enzyme, which comes from your lungs, ACE, converts angiotensin 1 into angiotensin 2, and this one causes your blood pressure to increase. And therefore, no surprise that the most successful and the most potent antihypertensive drugs, anti-blood pressure drugs, are what are called ACE inhibitors. They inhibit this enzyme, ACE, so angiotensin 1 never gets converted into angiotensin 2, your blood pressure goes down. And some examples of these ACE inhibitor drugs are ACE inhibitors, right? Like captopril, lisinopril, enalapril. All these pril drugs are ACE inhibitors, enalapril, okay? So just three prototypes that I will mention here. Very successful antihypertensive drugs. Aldosterone is another hormone which is secreted by your adrenal cortex. You talked about that during endocrine system, and that also causes your blood pressure to go up by retaining sodium, salt in your system, and increasing the formation of angiotensin 2. ADH, same thing, antidiuretic hormone, which is made in your hypothalamus and stored in your posterior pituitary. We mentioned all of that during endocrine system discussion. And ADH will again suck back water back from your kidneys, retain water in your body, and that will increase your blood pressure as well. ANP, or atrial natriuretic peptide, is the exact opposite. This is secreted from your right atrium, therefore the name, and it will cause you to urinate out salt, sodium, and water. So this will decrease blood pressure. ANP will decrease blood pressure and decrease fluid retention in your system. So patients with congestive heart failure, they are treated with ANP infusions, okay, to get rid of the extra fluid, to reduce their blood pressure. So hypertension or high blood pressure is when your systolic blood pressure, your upper reading is chronically elevated, higher than 140 millimeters of mercury, and your diastolic blood pressure is consistently, chronically greater than 90 millimeters of mercury. And this is dangerous because this puts you at risk for heart failure, for strokes, heart attacks, for aneurysms bursting, for arteriosclerosis, major cause of heart failure. In fact, hypertension is called the silent killer. 90% of your uh, hypertension cases that you see in people are what are called essential hypertension, which means what is essential hypertension? Genetic hypertension. There's nothing you can do short of taking medication. For 90% of high blood pressure cases are essential hypertension. So you might eat the healthiest of diets and be physically active. That will help to some degree, but essential hypertension is genetically inherited. It runs in families. You'll still likely need to be on antihypertensives for that. Hypertension is the exact opposite, low blood pressure. Many things can cause it. Pregnancy can cause it. Excessive urination can cause low blood pressure. Vagal overstimulation, vagus nerve overstimulation can cause low blood pressure, right? Not drinking enough water, hypotension, all those kinds of things. So dizziness, fainting is something you will see here. Orthostatic hypotension is a specific type of hypotension that you will see when someone gets up suddenly from a lying position, reclining position, to a sitting position and to a standing position, and then you see this darkness in front of your eyes, right? You black out and you pass out. That's orthostatic hypotension. Who is more at risk for these kinds of episodes? Diabetics, because they're chronically dehydrated too, right? Also people with circulatory shock, people who do not have enough blood volume, if you will. So when are the short-term mechanisms for regulation of blood pressure important? In body position changes, such as when you get up suddenly from a reclining position or if you stand up. What is the initial change to blood pressure when you arise in the morning? It increases, it goes up because your heart starts to beat faster. Describe the autonomic reflex to maintain your blood pressure when you arise. When you get up, the heart speeds up because your brain stem tells it to do that, and there's vasoconstriction going on in your major blood vessels. The blood gets to circulate back up to your brain. How is angiotensinogen activated to become angiotensin 2? Angiotensinogen is acted upon by renin from the kidneys to turn into angiotensin 1, and angiotensin 1 is acted upon by the angiotensin converting enzyme from your lungs to turn into angiotensin 2. And angiotensin 2 is a potent blood pressure controller. It makes your blood pressure go up. Which hormone decreases blood pressure? ANP, atrial natriuretic peptide. So what happens during exercise? During exercise, your blood flow goes to your heart, to your skeletal muscles, to your brain. All right. So that's the type of blood flow that you want. That's why you should exercise. However, also the blood flow to your skin picks up, and that's why you start feeling hot and you start sweating, right? Less blood goes to your gut and to your kidneys because that's not the time. When you exercise is not the time to eat or to urinate. Okay. So at rest versus exercise, you can see the blood flow increases to the brain, heart, skin, and skeletal muscles, but it decreases to your kidneys and your digestive organs, okay? Which organs have an increased proportion of cardiac output during exercise? Heart, brain, muscles. Which receive a decreased proportion of cardiac output during exercise? Your kidneys and your what? And your intestines. Okay, pulmonary vasculature, pulmonary circulation, we talked about that. Pulmonary vessels have much lower blood pressure as compared to your other blood vessels because pulmonary vessels are right next to the heart, not that much pressure needed. What is the percentage of blood returning to the right side of the heart that is then pumped to the lungs? Percentage of blood returning to the right side of the heart. Uh, let's see. So pressure drops to 10 millimeters of mercury in your pulmonary capillaries, okay? How does blood pressure in the pulmonary circulation compare to the pressure in the systemic circulation? Your pulmonary blood pressure is much lower than the systemic circulation. All right, so next up, basically, let's do this. 122. All right, so basically I'm going to stop here on slide number 122. This is where we're going to start on the different arteries and veins that supply the parts of the body, okay? Um, so I'm going to record the rest of this lecture next week along with the lymphatic system, okay? So let's see. Right, so rest of chapter 20 as well as chapter 21. And we will also start on chapter 22, um, which is the immune system somewhat, okay? So we'll do that. All right, so in the meantime, again, you have your work cut out for this week. You have units 19, or is that, no, 18 and 19 lab work to work on. You also have your lab exam study guide sent out. So prepare for your lab exam this coming Saturday as well. And then I will record the rest of these lectures and share with you next week. Today I will be sharing the notes that I took as well as the recorded lecture. And I will be grading all the work that you turn in the meantime as well. So stay safe, stay healthy, happy, and let me know if you have any feedback, any questions. Um, I will be more than happy to answer those. Um, and keep checking your emails for any communication from me. All right, so take care. I'll see you all next week. Bye-bye.